Okay, hi everyone. My name's Sasank. I'm going to talk about Code Blue, ACLS, targeted temperature management. So the first thing you do is you see an unresponsive patient. You want to check their circulation for their carotid pulse. If there's no pulse within 10 seconds, you check their airway and breathing. If there's no definite pulse within 10 seconds, then you start CPR or compressions immediately. And you'll call for help. So the first thing you want to do is call Code Blue, and then you want to call for defibrillator backboard, the ambulatory bag, and then you want to put on monitoring. So any telemetry, defibrillator pads, continuous O2 instruments, and then blood pressure cuff, and then put those on the patient. And then for your CPR quality, you want to compress 2 to 2.4 inches deep. Having a backboard underneath the patient will help you get quality compressions. And then you want to pump at a rate of 100 to 120 beats per minute. Some people use a staying alive song. And then you want to minimize any interruptions, allow for full recoil of the chest. So another thing you can do is in a patient, you can give the endotracheal tube so you can intubate them immediately, or if they're oxygenating fine, that's you can just leave them without a tube. You can use the bag mask, and you can oxygenate that way. So the next thing you want to do is you want to do a rhythm check as soon as possible. And so you want to do a defibrillation if shockable and epinephrine if non-shockable. So let's say at this point the team starts rolling in. So the first thing you want to do when the team arrives is you want to assign roles. You want to write everyone's name on the backboard and talk about who runs what. The senior resident usually is the one who runs the code. They make all the decisions, the rhythm checks, meds, shock, airway calls, escalation. The code whisperer is the one who whispers information and keeps the leader updated without distracting the whole room. And these people, they keep track of when the last epinephrine was given, the amount of shocks, the compression quality, the timing, the medications, the labs, ABG, lactate, and anticipating the next steps. And then the pulse. So this is the junior resident, so probably your second year, and this is the one who checks for a pulse during the rhythm checks, and they should only touch the patient during a pulse check to reduce the confusion. And compressions are done by the interns, and you can also bring Lucas, which is a machine that helps do the chest compressions. You might see this in the pit, the first episode. But okay, let's talk about the two pathways. Actually, let's talk about code tasks. So the code task is A, B, C, D, E, F, G, H. GH is added for maternal patients. So A stands for access. So you want to get peripheral access using a large bore IV in the brachial vein, medial antebrachial vein, or you can do the radial vein, I think. And then if you're not able to get IV access, you can do intraosseous access. So intraosseous access, you could either do proximal tibial or distal tibia, proximal tibia or distal tibia, or humeral head. Anything pre-tibial is not a good idea. But then make sure you know how to place an IV. There's a video that I've posted here that will work. But okay, let's talk about the two pathways. So the two pathways, you have shockable and you have not shockable rhythms. So not shockable rhythms, you want to do CPRs continuously and then check for rhythm and pulse every 2 minutes. But this whole non-shockable pathway, you do CPRs continuously besides the pulse and rhythm check. That's every 2 minutes. And you, for non-shockable rhythms, you give epinephrine 1 milligrams IV push. The way that works is you don't just give it all at once. You first flush with normal saline, and then you slowly deliver epinephrine over 1 or 2 minutes. You connect the tubing to the IV and then slowly push the epinephrine. And let's talk about shockable rhythms. So shockable rhythms, you do the rhythm check, and as soon as the pads are on, and then you shock if there's VTAC or VFib, and then for the shock you want to set it to 120 to 200 joules. And at the second attempt of a shockable rhythm, you administer epinephrine 1 milligrams IV push every other cycle. So say like it's a second attempt, and it's not successful, then on the third attempt you start giving epinephrine 1 milligrams, and then so the cycle after that you give amiodarone 300 milligrams, and the cycle after that you would give epinephrine 1 milligrams, and the cycle after that you can give amiodarone 150 milligrams. You can use lidocaine as well, it's a personal preference. But okay, let's talk about reversible causes of cardiac arrest. So you want to ask these questions in the middle of the code while the pulse and rhythm checks are happening. You want to assess for H&Ts. So hypovolemia is a patient like fluid depleted. If so, you give rapid IV fluids and you control the bleeding if trauma is suspected. If hypoxia, you give 100% O2, intubate if needed. You ensure good ventilation and check for airway obstruction. If there's a pneumothorax, you have to treat that. For acidosis, you want to increase the ventilation to blow off CO2. You want to treat the underlying cause. You don't give bicarb routinely unless specific indications such as tricyclic antidepressant overdose or hyperkalemia. For hyperkalemia, you want to give IV calcium, which is chloride or gluconate, to stabilize the myocardium, and then shift potassium inwards using insulin or glucose. You can also use albuterol, sodium bicarbonate, or you can use diuretics or dialysis. For hypokalemia, you want to replete gently after return of circulation. You don't want to do this during the code. For hypothermia, you want to warm the patient. You want to use blankets, warm IV fluids, and consider ECMO. Another thing is the ECMO has to be paged within 10 minutes of the code initiation. For tension pneumothorax, you want to do an immediate needle decompression followed with chest tube. For tamponade, you want to do pericardiocentesis. For toxins, you want to use the specific agents to reverse the toxicity. For thrombosis, you want to use thrombolytics or embolectomy. Before you give thrombolytics, make sure you check for contraindications. So these are usually any propensity for bleeding. And thrombosis, you want to do, if it's a coronary thrombus, then you do PCI or thrombolytics. But let's talk about other causes. So trauma. So the ATLS algorithm is important for that. The basic gist of ATLS is you want to first stop any severe bleeds, and then you do the ABCDEs, and then you do your secondary survey. Hypoglycemia is blood glucose less than 70 milligrams. You want to treat the hypoglycemia if confirmed. For adults, you give 50% dextrose, 50 milliliters IV once. For children, you give either 10% dextrose or 25% dextrose, and you repeat as needed. For hypomagnesemia or arrhythmia associated with QTC prolongation, you administer magnesium 1 to 2 grams IV bolus once. For hypermagnesemia or hypocalcemia, you give calcium chloride 5 to 10 milliliters IV over 2 to 5 minutes, or calcium gluconate 10%, 15 to 30 milliliters IV over 2 to 5 minutes. For asthma, you want to do airway management if it's an exacerbation, and assess and treat tension pneumothorax. If cardiac arrest occurs during mechanical ventilation, consider the management of dynamic hyperinflation. Basically, the auto PEEP, if it's keep going, then it might not be working effectively, and so you can't count on the respiratory status of the patient. Whatever it tells you, you have to do it manually. So anaphylaxis is you give epinephrine 0.2 to 0.5 milligrams intramuscularly once, repeat every 5 to 10 minutes as needed, and then intubate if necessary. And okay, let's talk about what are the metrics. So for respiration, make sure that the end tidal CO2 is greater than 20 millimeters mercury. And another thing is, if you have to do labs as soon as you can. So I assume that the way that this is done is as soon as you get IV access, draw labs. So ABG with potassium and hemoglobin, CBC, BMP, LFTs, lactate, type and screen, coags, fibrinogen, cardiac enzyme. You do these right away. And then if it's a pregnant woman, you want to make sure that you do left lateral uterine displacement, IVs above the diaphragm, and resuscitative hysterotomy if no ROSC within 5 minutes. And another thing for thrombolytics, so it's typically 30 milligrams to 50 milligrams bolus, and that is given over 5 seconds. And so from 60 kilograms every less than 60 kilograms is 30 milligrams, and from 60 to 70 is you increase by 5, and every 10 kilogram increase you increase by 5 until you reach a maximum dose of 50 milligrams. And then you want to continue CPR for at least 90 minutes according to ACC. And then after you break up the clot, you want to do heparin GTT. So that is 60 to 80 units of kilogram heparin bolus, and then a drip from 12 to 18 units per kilograms per hour. And yeah, so that is the ACLS algorithm. So just to summarize, so okay, let me just break it down in 30 seconds. So first thing you do, assess if the patient is unresponsive, you check their pulse. If there's no pulse, then you start CPR immediately and you call code blue, make sure your compressions are good, and you do the rhythm check as soon as possible. When the code team arrives, you assign the roles and you make sure you have IV access, airway is clear, and you go ahead and assess the rhythm after as soon as it's possible. And if it's a non-shockable rhythm, you give epinephrine 1 milligrams every 3 to 5 minutes, so basically every other cycle, and you're doing CPR continuously besides a pulse and rhythm check. But for shockable rhythms such as VTAC and VFib, you do the shock and then you give epinephrine after the second attempt is unsuccessful, and then you can add amiodarone on the third unsuccessful cycle, or you could add Lido or magnesium sulfate. And while you're doing this, you assess for any reversible causes and treat those. And at any point, if you get ROSC, you can go to post-care evaluation. Things for ROSC, basically, does the patient come back to life? Do you see that there's a respiration end tidal CO2 is greater than 40? You'll know if you get ROSC. And another thing is when you get IV access, make sure you draw labs right away. And so let's say that ROSC is not achieved after 20 minutes, then basically you can go into prognostication, which I'll talk about later. But yeah, that's the basic gist. And let's talk about post-ROSC stabilization. So first thing you want to do is HOV. So hemodynamics, make sure the MAP is greater than 65. How do you calculate MAP? It's 2 times diastolic blood pressure plus systolic blood pressure divided by 3. You can use IV fluids or pressors to help you get to that level. And then you want to make sure the oxygenation is 92 to 98%. You want to use ventilation if necessary. Make sure the end tidal CO2 is between 35 to 45. And you want to evaluate for any reversible causes, obtain a 12-lead EKG, consider other H&Ts. And if STEMI likely, then you call cath lab immediately. And then you go into targeted temperature management. And is the patient able to follow commands? Okay, temperature management, make sure the temperature is between 89.5 and 99.5 temperature Fahrenheit. And is the patient able to follow commands? If not, then you page stroke and neuro, consult neuro. And then neuroprognostication, this usually happens after 72 hours. And after 72 hours, there's a expert team that decides if the patient has, and also make sure that all the meds have worn off. So then after that, you want to consult the neuro team to do the neuroprognostication. The critical care and ICU docs can do this also. And they will see if there's brain death, basically. But yeah, that is ACLS for cardiac arrest, otherwise known as code blue.